Good afternoon, everyone. I'll change the tone a little bit, and my talk today is about phobias. And if any of you have watched a few years back this movie called My Big Fat Greek Wedding, you may remember a character who, proud of his Greek heritage, attributed the origins of everything to ancient Greece and used to say, "Give me a word, any word, and I'll show you that the root of this word is Greek." So, indeed, the word phobia comes from the Greek word phobos, which means fear. There you go. And this is important because fear is the defining emotion in phobias in the same way that sadness, for example, is the defining emotion in depression. And this canvas of emotions is a key concept in mental health because it helps us define mental health problems and at the same time normalize common and expected human experiences under certain circumstances. And fear is a normal and natural response when we perceive something as threatening and potentially harmful to us. So, for example, fear could be protective for children who are naturally afraid of water or fire, heights or strangers, and this keeps them safe. Some evolutionary theories suggest that fear helped us survive, as in prehistoric times we avoided poisonous spiders and wild dogs in hostile environments. Or even in the battlefield, those who happened to faint in the sight of blood were the ones more likely to survive for being killed because they were considered already dead. Another emotion which is associated with phobias is that of disgust. And again, you can understand that by being averse towards blood or vomit actually protects us from potentially contaminated bodily fluids. And also don't forget that fear is sometimes quite a sought-after emotion, like when we watch a thriller, a horror movie, screaming in a sort of fairground ride, or in extreme sports. So if, this canvas of emotions, if phobias is grounded on normal and natural human experiences that can be protective or even desirable, why are we labeling them as mental health problems and we are trying to treat them? It's all a question of degree. So if emotions were music, then they would have their own volume and tempo. So the louder the volume and the faster the tempo, the more likely that the music will become a problem because we wouldn't enjoy it and we wouldn't be able to do things alongside it. So the aim of treatment is to lower the volume and to slower the tempo so we are able to enjoy the music again, or at least the music blends in the background, or even better, it becomes boring. Because in the context of phobias, the point that we're trying to get to, the opposite of fear, is boredom. So the first step to treat phobias is really to unpack these three responses of fear. Is how our body reacts, the so-called fight or flight response, which is the result of excess adrenaline and excess oxygen when we are hyperventilating during stressful situations. The second response is what we think, how our mind works, creating these what-if scenarios. What if I make a fool of myself? What if something bad happens? What if I can't escape? What if I get hurt? And finally, is how we respond to the situation. So by either avoiding it altogether, or running away from it, or doing things that help us cope with the situation. It may be calling out for someone to come and pick up that spider on the wall, or closing our eyes when we're standing at the edge of a cliff, or averting our gaze when we're having an injection, or holding on to something comforting in the dark. So all these safety behaviors and avoidance, we know that they maintain fear. So these fear responses can be triggered by different situations, and depending on the nature of these triggers, we classify phobias into 5 types. The most common one is animal phobias, and here in the UK, typical triggers would be dogs and spiders and bees and birds. The second type, blood, injury, and injection phobia, may be triggered by things like the sight of wounds, medical and dental procedures, or even in young people, children and young people, talking about reproductive issues, reproductive education. Then there's sort of the natural environment phobias, things like water and thunder. Situational phobias are triggered by things like darkness and heights or enclosed spaces. And finally, a group sort of miscellaneous, which is things like vomit phobia or fear of choking from certain foods, or in children and young people, fear of costume characters like clowns or buttons. And we call these specific phobias to differentiate them from two other conditions. And these are agoraphobia and social phobia. The common denominator between these two is avoidance and anxiety around people and in public places. And the differentiating factor between the two is that the dreaded outcome. So in agoraphobia, the dreaded outcome is something bad happening and not being able to escape to a safe place. And in social phobia, the dreaded outcome is being scrutinized and being negatively judged. And I mention these because our research that I'm going to talk about now relates to specific phobias and does not include complex phobias because these do not lend themselves to one-session treatment. Because our research project, which was called Aspect, Alleviating Specific Phobias Experienced by Children trial, was really a comparison between one-session treatment and multi-session cognitive behavior therapy, or CBT. This was a 5-year program that has been completed and only recently published a couple of months ago. And the aim was to compare the outcomes and costs of these two treatment modalities. So what we wanted to find out is whether OST was inferior or not to multi-session CBT and whether it was good value for money. So we included, I think it was 268 children and young people aged 7 to 16 years across 27 different services. And then the children were randomly allocated to receive either one-session treatment or cognitive behavior therapy. Now, why cognitive behavior therapy? This was the treatment of choice because this is what we offer as a standard treatment in the NHS for specific phobias. And the basic premise of CBT goes back to those 3 fear responses that I mentioned earlier, that we're trying to change the way we feel by changing the way we think about a situation and changing what we do in response to the situation. So we followed up the children for 6 months, 197 of them. We couldn't collect outcomes from all of them because the last leg of the study was completed during COVID. And then let me cut to our headline finding. We found that one-session treatment is not inferior to CBT, and it was also cost-saving. By non-inferior, I mean that phobia symptoms like avoidance and distress in feared situations improves to a similar extent with one-session treatment as it does with multi-session therapy. And by cost saving, I mean that a service has to pay less to achieve the same level of improvement, has to pay less with OST than it pays with multi-session CBT. Okay, so how do we do this? Now, both CBT and one-session treatment use the same therapy technique. It's called graded exposure therapy. And graded exposure therapy has 2 steps. One is creating a hierarchy of triggers, and the second is turning this hierarchy to graded exposure tasks. Now, a hierarchy of triggers is really a list of all the sort of feared situations put into some sort of order of how stressful they would be if the child, the young person, were to encounter them at that given point. So let me give you some examples based on the 3 main groups of phobias that we saw as part of our Aspect research project, and that accounted for 84% of our sample. So with the 3 common phobias, one was the animal ones, spiders and dogs. The second was vomit phobia, and the third was blood, injury, and injection phobia. So a typical Fear hierarchy for spider phobia, as you perhaps imagine, is things like drawings, cartoons of spiders, pictures, videos. These include sort of small and large spiders, nothing grotesque or over the top, it's just like the normal house spiders. Then you may have dead spiders, live spiders of different colors and different sizes, or even things that resemble a spider, like the stalk on top of a tomato. A fear hierarchy for vomit phobia will include, the sight, the smell, and the sound of vomit. Again, with video clips, with pictures. It may include fake vomit, sort of the smell, again, the sight, or even touching it. I won't go on, not to put you off your dinner. For blood injury and injection phobia, it would be things like handling needles of different sizes, or phlebotomy and sort of medical equipment and paraphernalia. It might be reading or watching something that has to do with reproductive health. Things like watching someone having an injection frame by frame, or practicing drawing blood from a fake medical arm. All these things, so you can get a sense of what I mean by fear hierarchy. And the next step is converting this into graded exposure tasks. And by that I mean sort of confronting these situations in small increments without safety behaviors, and as long and as many times as is needed for fear to turn into boredom. So let me just sort of illustrate how a one-session graded exposure therapy would look like with dog phobia. So if you have a child, let's call them Johnny. It all starts with the therapist and Johnny sitting outside a room with the door shut, and inside the room, at the far end of the room, you can see a dog and its handler. So the dog sits with a sort of bottom facing the child, so not his face or his teeth. And then we stand there with the door closed, looking through the window of the door, until Johnny says, I'm bored now, or we're ready to move forward. And then the therapist demonstrates, opens the door, takes one step, stands there for a while, closes the door, and goes back. And then asks Johnny, would you like to try to do this together? So they do it together, open the door, close it. And then ask Johnny, would you like to try this to do it on your own? So Johnny steps forward, opens the door, stands there, and closes the door. And we do this again with first modeling, then doing it together, then Johnny leading the way. The parent is not there until we sort of reach the dog, and that may take 2 hours, reach the dog within touching distance. And now, of course, at this point, we get stuck. Johnny does not want to touch the dog, so the therapist may put their hand on the dog, and then Johnny put their own hand on top of the therapist. So they're stroking the dog, and then the therapist slides the hand away until Johnny can feel the soft fur of the dog themselves. And then they start stroking the dog, starting from their bottom all the way to their head. Next step would be to feed the dog. And again, we get stuck because Johnny is really scared of the dog's teeth. So what we do is we put the dog treat into a spoon, and then Johnny holds the spoon, or the therapist holds the spoon, and Johnny holds the therapist's hand. You feed the dog, and then perhaps you rub a bit of sausage roll on Johnny's hand, so the dog will lick it as opposed to using their teeth, and then Johnny will hand the dog the sausage roll to eat it from their hands. Then they take the dog for a walk around the room with a lead, and then we go outside, dog off the lead, and then Johnny throws the ball for the dog to catch it. So this will be a typical sort of 3-hour time-lapse, 3-hour one-session treatment for dog phobia. So what next, I hear you say, because of course we found that this is an effective and cost-saving alternative to the way we treat phobias at the moment. And you can imagine that it can be life-changing for people. Can you imagine a young person who can now have vaccines, or attend hospital and dental appointments, or go to lessons and read and watch things about reproductive health because they no longer have blood injury and injection phobia, or a 16-year-old who is able to go out with their friends and eat in public because they no longer have vomit phobia, or a 7-year-old who can go to the park or the seaside because they are no longer scared of dogs or birds. So the next step really is to disseminate our findings and train people professionals to be able to deliver this at large scale. And we will do this through our newly established Institute of Mental Health Research. And the aim of the Institute is to bring together more than 30 departments, schools and offices at the University of York whose teaching, practice and enterprise relate to mental health. And by doing this, we are able to really extend the reach and impact of our research beyond my own and our own networks and academic circles, and also extend the legacy of aspect of this research trial beyond the end of the research grant. And on that note, I should thank really the NIHR, the National Institute for Health and Care Research, who gave us the grant, and also thank colleagues, especially Professor Barry Wright, who led Aspect until his retirement. And thank the participants and all the colleagues who really contributed, of course, YorkTalks folks for their meticulous organization, and thank you all, most of all, for listening. So I'll stop here.